All right, well, we think we've got a great crowd today, so thank you so much and welcome. Thank you for joining us for this second event in our Future of Healthcare series. A couple of housekeeping notes. Please note that we are live captioning. If you'd like to participate with that, you can press the captioning button on your Zoom screen. Also notice that we're going to have a live chat. It's going to be a one-way chat where we share some information about our speakers and our backgrounds through the chat. So please take a look at that if you like any of those resources. We're also going to have a Q&A box. This is your opportunity to put questions in anytime throughout the program, and we definitely welcome those. This is an interactive panel conversation, and so we'd love to have your questions in that Q&A box. Please also note that we are recording this program. We will be sharing the recording on our Future of Healthcare series website, where you can also find the event that we held in January if you'd like to see that recording. So again, welcome. My name is Asha Shelzo, and I serve as the director of the Health Law and Policy program here at American University, Washington College of Law. I collaborate with Maya Mannion, our faculty director, and just a terrific bench of faculty and staff. Excuse me, our stellar faculty are experts across health law domains, including reproductive health, food and drug, compliance, fraud and abuse, bioethics, disability, and birthing decision-making. The mission of our program is to graduate students who are practice ready and prepared to launch meaningful, impactful careers. This Future of Healthcare series is just one of the many types of programs that we put together to serve that exact purpose. So the Future of Healthcare series examines trends, challenges, and opportunities in healthcare and the role of law and policy. We purposely highlight both practitioner and scholar perspectives on a wide range of topics. All of our conversations center around timely topics in healthcare through the lens of health equity. To be honest, the way we think about our program is that the pursuit of equity inspires our dedication to health law. We're also very pleased to partner with two terrific leading professional associations in the healthcare industry, the American Health Law Association and the American Society of Law, Medicine, and Ethics. We invite you to learn more about them by looking at their web pages. We're going to share those links in the chat. We're really grateful for the support of organizations like AHLA and ASLME. They provide so much enrichment for our community. So today, let's get to our program. We have just a wonderful audience and a really, really important topic and robust topic. Today, we're going to be talking about rethinking health reform and the role of Medicaid in advancing health equity. We're joined by three terrific panelists. Our panelists are Clifford Barnes, who's shareholder of the firm Epstein, Becker, and Green, Leo Cuello, who is research professor at the Georgetown University McCourt School of Public Policy Center for Children and Families, and Nicole Huberfeld, who's Edward R. Utley Professor of Health Law at Boston University School of Public Health, and Professor of Law and co-director of the BU Law Program in Reproductive Justice at Boston University School of Law. I am really delighted and grateful to these wonderful panelists for sharing their expertise with us today. We have a wonderful crowd. I'm very interested to hear from you and to learn from your expertise. And so what we thought we would do, just again, this is informal, interactive. We'd like to just start with some introductions. I've given you their basic title. You can look in the chat to look up their bios. But I just asked each panelist if they would share a few minutes of a little bit about their background and their work and how it intersects with our topic today. So I'll start with Leo.
Thanks so much, Ash. I really appreciate it. And thanks so much to American and Washington College of Law for having me. I work on a range of Medicaid issues. I'm a lawyer by training. I started out in a legal services type organization in Pennsylvania, the Pennsylvania Health Law Project, doing direct representation and policy work in Medicaid. And then I served as the director of health policy for the National Health Law Program in DC, where I arrived in 2009 to work on ACA design and then implementation. And then during the Trump years, ACA defense. The National Health Law Program was sort of the leader of some relatively high profile litigation to stop the Trump administration's work requirement policies in Medicaid. And I was involved in that work. And now I've been with the Georgetown Center for Children and Families for almost 2 years now. It's a lot more fun to work on policies to improve Medicaid as opposed to preventing it from being dismantled. But I really do work on a range of Medicaid topics. Maybe some areas of specialty for me our Section 1115 demonstrations, managed care, and other delivery system reform efforts.
Thank you so much for being here, Leo, and we're definitely going to explore many of those topics. Nicole?
I want to echo Leo's thanks. Asha and Tori have been wonderful organizers, and thanks also to Maya. I understand she may be giving a talk herself at this time and may not be joining us, but I know that she was important to this event as well. So thank you to all of you for gathering us together and gathering together people with so many different kinds of legal and policy backgrounds and interests. So I actually started practicing law in New York and New Jersey and always was drawn to health law because I, as an individual, have had a lot of healthcare experiences. So it makes me sympathetic to the plight of people who are going through our healthcare non-system and have no idea how to navigate it. But I also represented healthcare providers when I was in practice, and I did a lot of healthcare fraud and abuse work, and I did a lot of compliance work. And I found a question I got a lot of the time was, why do I have to do this? And the answer was almost always because you take government money. And it led me to think about that power that Congress has to influence health policy with money, the power that the states, that local governments and Congress wield together and sometimes in conflict, and how that impacts access to care. And so as an academic, these are things that I've studied quite deeply. I've studied implementation of the ACA quite deeply, especially focusing on the dynamics of Medicaid expansion. But I also think more broadly about law as a structural determinant of health. And it has always been clear to me that the way that law operates absolutely makes it possible or impossible for people to get access to the care that they need. It has also long been a bee in my bonnet that we treat public health and individual medical care as if they are different, when in fact they're two sides of a coin. So I'm hoping that we'll get chances to talk about these things today. Thank you.
Absolutely, will do. And I did notice you mentioned healthcare non-system, so we'll definitely come back to that as well. Clifford Barnes, Cliff?
Yes, thank you. Thank you again. And let me also chime in about the thought leadership that American has shown over the years. I mean, I've been actually on a couple of panels and they've all been well received and groundbreaking. And I think this is just another one. So thank you again for including me. I started in public health. I went to business school and came out in health management and worked at the health department in New York City. Actually, my boss was the chair of the board of the Health and Hospital Corporation, which is 19 municipal hospitals in New York. And I was an assistant to him in that role. And it was a great exposure to me. And at one point in time when I was 25 years old, he said, Cliff, he thought there was a real future in health law. And at 25, my future was the weekend. So I had no idea what he was talking about, but I knew he was a smart man. So I took him up on it and eventually went back to law school and came to Washington, and I've spent now the last 40 years with Epstein, Becker, and Green in health law. And Epstein, Becker, and Green started, interestingly enough, in managed care. Steve Epstein, the founding partner, became the in-house counsel for the Nixon demonstration project and health maintenance organizations. And when it ended in 1973, he came out and started representing these all nonprofit managed care companies. And it's probably the only law firm that started in an area where there was no law. There was literally no law that impacted health maintenance organizations at the time. So we ended up helping to develop the law and then to hold the plans accountable to the law. So it's an interesting job if you can get it. And as a result of that, when I joined the firm, I actually got interested in Medicaid. It wasn't an area that the firm was in, but it was just of interest to me because I thought access, managed care provided and presented a great possibility to provide access to Medicaid recipients that they currently didn't have in the fee-for-service market. And that interest actually developed into clients, which was an interesting thing for all those that are on the that are listening in, your passion can become your profession, and if you can do it, it's probably the best thing you can do. Fortunately, it was in my case. But I ended up beginning to work in Medicaid managed care in the early 80s. I helped founded the current National Trade Association, Medicaid Health Plans of America. I've been involved in Medicaid managed care, both on the provider side and the payer side, since the early 80s, and continue to enjoy that work.
Thank you so much. And wow, we can see just the depth of experience and expertise and the different perspectives that we're going to bring to this conversation. So let's kick it off. I will ask sort of with some help from you all to build some foundations here for the folks that are listening in who don't necessarily do this work every day like you all do, but certainly have some knowledge and sophistication around the topic. So if we could just spend a few minutes just framing the conversation, building a foundation. With health reform under the Affordable Care Act, we know that we see implementation now at around the 10-year mark. So maybe, Nicole, you could start us off a little bit. What does health reform look like, 10 years into implementation? What has the ACA achieved? What would you say the impact has been just in terms of the recent administrations, President Trump and President Biden, the impact of COVID? I'm asking you a very broad, overarching question just to get us going. And frankly, a lot of ACA litigation is still ongoing. And we're still talking a lot about coverage, so just would love for you to kind of help us flesh that out a little bit, build a foundation for us on some of these questions to kind of get everybody a little bit caught up and oriented on where things are now.
Great. Thank you, Asha. I'm going to go ahead and just share my screen for a moment. And I think it is important to recognize that the ACA is still worth centering in our conversation, even if people think we're past this point, because we had the 10-year signing anniversary in 2020, and it was pretty quickly submerged beneath COVID. And I think we had some important moments of trying to figure out the durability of the ACA, the meaning of this law that really shifted our understanding of who gets included and who gets excluded in US healthcare. But we're coming up on the 10-year implementation anniversary of the ACA, which in some ways I think is even more important. And so to me, this is a story of 3 very different presidential administrations dealing with different cultural, social, civic issues. It's a story of not just judicial decisions, not just legislative policy making, not just executive policy making, but the headwinds and successes that have come out of each of those 3 phases of the ACA. And so I'd like to just note that sometimes when I have these conversations with people, it feels like the more things change, the more they stay the same. We've been talking about equity in healthcare in the United States for a very long time. And injustice in health, as Martin Luther King Jr. said rightly, is one of the most shocking and most inhuman because it results in death. And so I want to center that concept in this conversation, because when President Obama signed the ACA, he made broad statements about how he thought he was sort of ending our health reform conversation. And this was important. He really did think that this was a shift in the way we would think about healthcare in the United States for good reasons. Before the ACA, we really did have a system where if you could pay, you could get care. And that is a private law-based system. It's an exclusionary system, and really not a system at all, but rather a bunch of fiefdoms, sometimes aligned. And so the ACA flipped that script and made it so that there was a principle of inclusion, at least in terms of getting to near universal insurance coverage. And in the United States, the question is, can you pay? And so getting to near universal insurance coverage was a really critical way to try to level the playing field and make it so that people could get access to care in the US. Almost immediately, though, the Obama administration became mired in litigation over the constitutionality of the ACA, the outcome of which was, of course, the first decision on the ACA, NFIB versus Sebelius, which made it so that the law remained in place, but also, as everybody here knows, made it so that Medicaid expansion, which was mandatory as the ACA was drafted, became effectively optional for states. And so right away, the Obama administration had to shift gears and start trying to get to yes on Medicaid expansion. This had a couple of ripple effects. One ripple effect was that as a political matter, state leaders decided that not only would they protest the ACA by not expanding Medicaid, but they would also not participate in creation of their own health insurance exchanges, thereby shifting the exchanges to the federal exchange. And everybody remembers that was a bit of a mess at first. So that was the one thing that took up the Obama administration's time that was unexpected. Another thing was the degree to which Kathleen Sebelius had to negotiate with states to try to get them to yes. And this was what really made it so that 1115 waivers became central to Medicaid expansion, because they became a vehicle for states negotiating their own version of Medicaid expansion under the ACA. And some states did that with an eye toward improving Medicaid, improving coverage, but some states did that with an eye toward trying to erode that new baseline that was created in the ACA by doing things like trying to introduce premiums into Medicaid, which is typically not permitted. So the Obama administration spent its time defending the ACA through really aggressive litigation, trying to get states to yes on Medicaid expansion, negotiating constantly with states, and watching as states learn from one another through horizontal federalism and tried to figure out what else they could get, what other concessions they could get from HHS. The Trump administration entered office, and the first executive order that President Trump issued was an executive order undermining the Affordable Care Act. So his position was clear from day one. He basically said, to the extent possible, my administration is not going to enforce the terms of the Affordable Care Act. And then for the 2017 calendar year, Congress tried to repeal and replace the ACA, which had the effect of creating confusion surrounding the law and its status. If there's confusion, people won't use what is available to them. And it has the effect of decreasing access to care, even if the law is still in place. Now, of course, by the end of 2017, what we had was the Tax Cuts and Jobs Act, which made it so that the penalty for failure to carry insurance was zeroed out, even though the so-called individual mandate is still part of the law. And then, of course, there were other efforts to undercut the ACA by the Trump administration. So refusing to pay the cost sharing that's required on the exchanges, trying to introduce elements into the Medicaid program that are not lawful, like work requirements, and generally efforts to try to undermine the principle of universality that's part of the ACA. Biden administration comes into office, and on day one, the Biden administration says, I'm going to try to embed equity in everything the federal government does. And so there were a whole bunch of executive orders, and I think actually President Biden may lead in the number of executive orders in the first 90 days of, or first 100 days of all presidents, but I could be wrong about that. So he tries to embed equity across everything the federal government is doing. Of course, number one on that list was addressing COVID. And also undoing some of the inequitable moves on the part of the Trump administration. So things like the so-called Muslim ban, trying to make sure that sexual minorities were protected under Section 1557 of the ACA, unwinding census changes. And then day two was creation of a health equity COVID task force. And then by day 9, what we got was 2 executive orders that reopened the health insurance exchange run by HHS, the federal exchange, so that people could have a special enrollment period and get health insurance during the COVID economic and health emergency. And that also directed federal agencies to examine the policies that undermined the ACA and attempted to sort of boost back up implementation of the Affordable Care Act. So the Biden administration has sort of swung the pendulum again, but much more concretely has tried to center health equity in its decision-making about how it will approach questions of healthcare, public health, and health reform. Despite all of this turmoil and litigation, remember Texas versus California was not that long ago, and despite the public health emergency, right? And despite the fact that this isn't what our country looks like, which is what it would have looked like if we had the ACA as it was drafted. Rather, what we have now is a country that is still a mix, right? Because we still have states that have not adopted Medicaid expansion. North Carolina, of course, is the most recent one, and it's a big win. It's more than 600,000 people gaining Medicaid expansion coverage. Texas, Florida, Georgia, those are the other big 3. And yeah, I don't know that that needle's moving anytime soon. Nevertheless, Medicaid expansion is one of the most studied health insurance changes in our history. And that shows us, more than 600 studies show us, that despite this turmoil, despite these headwinds, the ACA is also a success story, that we have the lowest rate of uninsurance in decades, that Medicaid expansion actually does improve access to care, it improves health status, it also improves underlying determinants of health. It makes it so that people have more stable housing, better access to the money that they need to pay for food, right? And there are studies that show that eviction rates have gone down where Medicaid expansion has been implemented. It stabilizes hospital and provider budgets because they have fewer uninsured patients that they have to accommodate. And it also stabilizes state budgets. So Medicaid expansion has had many ripple effects. And it has done a fair amount of work to equalize status of people in terms of uninsurance rates. Now, we do still have differences in uninsurance rates, as you can see here, but these are crucial leveling elements that were meant to be part of the ACA. In some ways, this is also a democracy story because state ballot initiatives have been crucial to Medicaid expansion efforts. And we see that carrying over now in terms of reproductive justice and what's happening in terms of voters trying to weigh in on what they think their state should do in terms of abortion and reproductive care policy. So maybe we can talk about that a little bit more later. All of that being said, coverage remains incomplete. And this has ripple effects too. Now, this map is slightly outdated, but what it represents is that there are real effects for states choosing not to implement Medicaid expansion. And one of the real effects is that hospitals close more in Medicaid non-expansion states. And or if they don't close, they close departments that are expensive, like obstetric and gynecological departments that make it so that we have maternity care deserts in the United States. I would also note that most of the people who are the most vulnerable demographically, people who are low income, Black populations, people who are more likely to be enrolled in Medicaid, also tend to live in the Deep South and are more likely to be affected by states' choice not to expand Medicaid, which makes it so that the end of the public health emergency is even more critical in these states and the fear that millions of people will be disenrolled in these states. I would also note there's ongoing litigation in Braidwood versus Becerra that challenges payment for preventive care under the ACA, and that might be something that we should talk about today as well. I should probably stop there so that my colleagues have a chance to weigh in on this first critical question.
Yeah, absolutely. Thank you, Nicole. And actually, if we could just do a quick follow-up, the question is coming in the Q&A, and I think it's a great question about how are we defining equity or health equity? And just so, because that's sort of a foundational question that, because we're using this term, and I'll just say that just in my mind, in terms of how I think about this work that we do is a general sort of understanding or expectation or an opportunity, I should say, that everyone has to attain their highest level of health. You know, like there's the removal of barriers or obstacles to achieving your highest level of health, whether they're structural barriers, legal barriers, you know, social barriers. So that's my rough definition, but I would invite any of the panelists to give a brief, you know, definition that they use or think about when they're doing this work.
Well, I can chime in there because that leads right into some of the comments I had, but looking at the CMS definition, it's very consistent with what you have mentioned, but they say it's the attainment of the highest level of health for all people, where everyone has the fair and just opportunity to attain their optimal health care, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or any other factors that affect access to care and health outcomes. So the focus is on access and health outcomes and the ability to optimize health wherever you are.
Thank you, Cliff. And why don't we hear from you then as well, because we've heard a great foundation from Nicole about the ACA and what implementation looks like and what are some of the sort of concerns looking ahead. But Cliff, from your perspective, just kind of taking a different angle from those items, like looking about it, what else has the ACA done from a perspective of innovation, delivery and payment? If you'll give us a little bit of foundation there.
Yeah, no, I think Nicole spoke early on about President Obama having a focus that he thought that the ACA would change the way we think about it. And I think this other goal of the ACA, the main purpose of the ACA, the third main purpose, in addition to health reform and expanding coverage, is also to support innovation in healthcare delivery and healthcare cost, and to stimulate value-based purchasing design. So early on, the ACA had a focus on developing innovative approaches so that we can kind of figure out how to modify the way we deliver and pay for healthcare. And so as a result of that, in 2010, Section 3201 of the Affordable Care Act established the Centers for Medicare and Medicaid Innovation. And that center, their purpose was to develop and test new healthcare payment and delivery models to improve patient care, lower cost, better aligned payment system, and promote, and this is a key phrase, patient-centered practices, because at the heart of health equity is patient-centered care. And I'm going to talk a little bit about how CMMI has developed that focus and policy, as well as CMS has developed that over these last few years. You might recall that in 2010, CMS covered 100 million people. Today, it covers almost 150 million, which is, I guess, a good 40%, if not 45% of the population of the United States. So they have a big role in how healthcare is delivered and paid for, since they're paying for a big chunk of it. But I talked about CMS and CMMI. CMI has now launched over 50 different payment models. They have impacted through those models more than 20 million patients and more than 200,000 providers in these tests and innovation approaches. And as a result of that, we have created these concepts of the accountable care organization, bundle payments, medical homes, and value-based payment arrangements, all of which I think are foundational to where we're going in the healthcare system, as well as developed Medicaid expansion and developed approaches through the 1115 waiver on what that looks like. Important is that the evolution of CMMI today, they have an approach that focuses on health equity, and as part of that approach, they have they've stated 5 goals as of October of 2021. The first goal is to drive accountable care, and accountable care is really getting the appropriate incentives for participating providers to be able to practice and deliver patient-centered care. And to me, this is the game changer. The game changer is that traditionally, healthcare has been what we could call a sick care system, where the provider stayed in their office and the patient came to the provider once they're sick, and the provider provided services. This drive for accountable care, and we're going to see this as I lay out the other 4 focus of CMMI, is really about shifting care so that the provider needs to understand where the patient is, what the condition of the patient is, and integrate that information into providing services. And I'm going to talk a little bit more about that. The second focus of CMMI is advancing health equity. And health equity are new models whereby you collect and report demographic data, as well as social needs data and social determinants of health. And this, I think, is the big change. To integrate demographic data, social needs data into clinical decision-making is going to require a whole change in the way that we handle protected health information, the way in which insurers and providers exchange information, and for the health lawyers on the call, it's going to change your uses and disclosures. It is actually mind-boggling when you begin to unravel the kinds of changes that integrating all of that information is going to require. The third focus of CMMI is support this care innovation. And the focus is on, again, this personal, person-centered care that integrates clinical needs and social needs. And so that providers and payers are going to need to look at both of these sets of data and make decisions, again, based on both of them. Moving to CMS, in terms of CMMI has now impacted the goals of CMS, which have recently been stated as the vision of CMS is a healthcare system that achieves equitable outcomes through high quality, affordable, person-centered care. Again, this person-centered care. Their goals, as stated most recently, is that health systems recognize that they must meet people's medical needs by considering their preferences, their values, the circumstances to keep people healthy and independent. And so it's a movement towards health care and well care from sick care. I do believe it's a beginning, but I do think that the CMI focus in innovation is going to have a dramatic effect on healthcare as we move forward. Let me just, before I close, go back to this history of health equity. Health equity as a concept actually started in 2015, where CMS had its first strategic initiative around health equity, which was focused on the Medicare program. Interestingly enough, during the Trump administration in 2019, health equity was expanded to all of CMS's programs. And then in 2022, CMS redesigned their framework to develop a health equity framework. And that framework has 5 priorities. And the first priority is to expand the collection and reporting and analysis of standardized data. This gets back to what I mentioned earlier about patient-centered care. The need to collect, report, and analyze data is going to change the way healthcare is provided. We've got a long way to go, but I think the foundation for that change is being set by CMS today. That second priority is really about accessing the causes, being able to assess the causes of disparities within CMS's programs and to address inequities. And we see today through the Medicare revisions in Medicare Advantage, Medicaid managed care, and the 1115 waivers, how these principles are beginning to infuse the services that all of these entities are providing. And I'll stop there, but I think that, again, one of the primary legs of the three-legged stool of the Affordable Care Act is this development of innovation with CMMI. And I think it's going to have a continuing ripple effect in healthcare as we move forward.
Absolutely. Thank you for giving us the perspective on innovation and what ACA implementation has done there. Let's circle back, though, to the question of coverage, and which still is a persistent question, right? And why do we have still so many uninsured people? Leo, maybe you can tackle that for us.
Sure. And I want to sort of pick up on Nicole's great ACA update and think of how it fits in with the whole system. And so I have a sort of conceptual visual for you if I'm competent enough to share my screen. And you all can wave your hands if it didn't work. If you look at kids, we have a seamless system. We have Medicaid coverage, and for higher income kids, we have CHIP. And right above that, we have marketplace subsidies that go all the way up to 400% of federal poverty, which is reasonably high. For adults in expansion states, which is like 40 states now, in the second column, you can see we have Medicaid to at least 138% of federal poverty, and there may be a higher Medicaid limit for some other categories of coverage, like for pregnant people. But from whatever that Medicaid limit is, you then have marketplace coverage, again, up to 400% of federal poverty. So I want to start by pointing out, we have coverage vehicles. The ACA was by no means perfect, but it left us with a seamless coverage system, at least in theory. Now we have the major imperfection in the third column that Nicole highlighted, the coverage gap problem. And I don't want to diminish the importance of the coverage gap. It's millions of people without coverage. It's disproportionately Black and brown people without coverage. It's a human tragedy. But first, I want you to note, it's not the lack of a coverage vehicle. It's not using the one we have. More importantly, in fact, it's only a part of the problem as to why this theory isn't reality, because we have other major systemic problems going on. And I think that's actually the next generation of health reform. And it's different because it might not be about creating new coverage vehicles. So I'm going to show you one more slide based on great data from the Kaiser Family Foundation. Who are the uninsured, right? And here's the thing. The coverage gap in gray is only 8%. It's the smallest piece of this pie. So even if we fix the Medicaid expansion problem, 92% of the work is still left to be done. That may be surprising to you. But the thing that I want to jump out at you about this chart before we dissect it a little, the screaming headline for me is 25% plus 38%, so 63% of these people are eligible but unenrolled in our coverage vehicle. That is theory, our coverage vehicle crashing into the brick wall. So let's get into this. We're going to set aside the coverage gap because, as we said, the vehicle is already built, but this might be a good Q&A topic. The yellow slice, 16%, is people who have higher income or employer-sponsored coverage available. There are some issues with whether that employer-sponsored coverage is truly affordable for everyone. But ultimately, I care about those people, but this may be the cost of a system based on employer coverage and subsidies. It just might be the case that some people who have options won't take them, even if they have the resources to do so. So what I'm saying is my goal is that this 16% becomes the whole pie, and we have a conversation about how to fix that problem. The green slice is immigrant populations, and I think this one is somewhat straightforward. You don't need a new coverage vehicle. It's just a political will problem of letting them into the vehicles that already exist. Obviously, this is first and foremost a moral failure. But I think at its core, practically, it's also an information problem. When you look at the actual evidence, what immigrants can contribute to this country financially, their importance in our labor market, the importance to public health, the inescapable conclusion is we need to let them in. And so that leaves the eligible but unenrolled groups. So first we have the 38%, the people eligible for marketplace subsidies and not taking them. We know a big problem is that there are a lot of people who are tax credit eligible, but the subsidy isn't enough that it's really affordable for them. Recent legislation has temporarily increased those subsidies quite a lot since this data. So that should bring down that 38% number. And the Biden administration has proposed to make that permanent in their budget. There's also a continuity problem, though. People getting dumped from Medicaid, but not successfully enrolling, which we'll get into. And then you have a policy question, right? Which is without an individual mandate or some equivalent policy that encourages healthy people to enroll, can you ever get this 38% number to zero? Or will our hybrid public-private solution always have some gap here, much like the yellow slice, right? And so that leaves the slice I want to talk about the most. The individuals who are eligible for Medicaid, but not enrolled. And in some ways, this is the most unbelievable piece of the pie. These are some of our most vulnerable populations. The coverage is free to them, but they're not enrolled. How can this be happening? So the short answer is, first, the obvious problem that many people who are eligible haven't applied or successfully gotten in the door. They don't know they're eligible or know how to apply or some similar problem. But second, there's the dirty secret, which is that once you do enroll in Medicaid, you have these regular annual renewals, sometimes more frequently, sometimes eligibility renewals or reviews when there's even a temporary change in household income. And many, many people get terminated through these policies, through these processes. And in many cases, it's because of a paperwork problem, even though they're eligible. So many people, many eligible people don't get in through the front door. And for those who do get in through the front door, we throw a lot of them out the back door in the review process. And so, it's so easy to get terminated from Medicaid. Since Medicaid eligibility is based on monthly income, people who have fluctuating hours at their job, which is super common in this population, right? They're eligible in January. They get terminated in February when their income goes up because they picked up some extra shifts at work that month. And then they might need to re-enroll in March when their job returns to normal. We call this churning. And sooner or later, people lose coverage and they slip through the cracks. In some cases, they don't even know it happened. In many cases, they never find their way back into the system. So we have a huge continuity and retention problem. During the pandemic, we've had mandatory continuous coverage and enrollment increased dramatically, in large part because we stopped terminating eligible people.
Thank you, Leo. Will you pick up on that though, and then help us think about how to fill in these gaps or what are some solutions for this?
Right. So we have these enrollment and retention problems I discussed. And for Medicaid, we do have some policy solutions already moving forward. For kids, there's 12-month continuous eligibility, which basically locks in their coverage for a year once they get eligible, regardless of household income changes. And it's currently optional, but most states are doing it. And starting January of 2024, it becomes mandatory for all states. So that's a great step. But of course, it means they can still get dumped at the end of that year. Even more exciting is we have a couple of states that are moving to implement multi-year continuous eligibility for kids. For example, Oregon will enroll kids continuously from birth to age 6. So that's really an amazing step forward. And, in my day job, I do cartwheels about that kind of thing. We also have a great policy around postpartum coverage, extending coverage for a full year after birth. And now over half of the states are doing that. Hopefully that too will be mandatory one day. So we're taking steps forward. And as somebody kind of working in this trench, we're taking the biggest steps we can, given the politics and the budgets and the options in front of us. But if we're talking about the next generation of health reform or system building, we have to dream bigger. So my simple question is, why does eligible but not enrolled even exist? Why does that even need to be possible? What if everybody is just in and you can't be not in? You can't be a fish out of water. So let's talk about what that would look like in our system. And to do this, I want to keep it real and ask you to put yourself in the mindset of a state budget hawk so you understand the incentives at play. First, you, state budget hawk, are liable for Medicaid payments for everyone in your state enrolled in Medicaid. So there's a structural incentive to keep enrollment low. Second, if a person's income goes up and they become ineligible for Medicaid, they can go to the marketplace with subsidies, and that is 100% federal money. You pay nothing. So the moment the person is no longer eligible for Medicaid, you would, if you could, terminate them 1 second later, right? And have them go over to the marketplace because they're no longer your responsibility. The takeaway here is states run on very thin budgets. So there's a huge built-in incentive for them to keep enrollment low. And remember, they control Medicaid enrollment and to expeditiously get ineligible people out of coverage. So I think you have a revolutionary, unrealistic solution, which is you federalize the Medicaid program and you get the states out of the business entirely. We don't have this type of problem in Medicare. But more realistically, the first thing we need to do is to develop some kind of deal with the states. We're going to invent some magic continuity solution to get enrollment up to 100%. You're going to have more enrollees to pay for, but we're going to increase your matching funding to make up for the difference or a large part of the difference. That requires federal legislative will, including to pay more money and some good lawyers to defend the lawsuits. But then that just begs the question of what's the magic continuity solution? And I'll throw out two concepts. I think one option is we use the continuous eligibility model. We figure out how many people are popping back and forth across programs, and we boost this payment to the states to account for that during, say, a 2-year continuous eligibility time. We basically funnel the money that the feds are saving to the states. That's not impossible. Of course, the continuous eligibility runs out every 2 years and people will still get dropped as they get moved around. So let me suggest a second solution. It's basically a pay and chase model. No one ever gets terminated. You can't be not enrolled. Instead, the states and the feds and other payers bill each other for the costs they pay for what should be someone else's enrollee. So I'm in Medicaid, I stay in Medicaid until I am actually and successfully in the marketplace. So there can be no gap in coverage. And if the state paid some money it shouldn't have while I was in Medicaid a few months too long, it bills the feds. And of course, over time, you could make anticipatory payments based on historic averages and then reconcile the small variations you're left with at the end of the day. I'm not saying this is easy, but it doesn't sound any less feasible than hundreds of millions of people making anticipatory tax payments and reconciling those. Reminder, that's in a few days. We seem to do that, right? So if we want to have this system with all of these different coverage types and payers, we need something like this. So I think that's the next wave of health reform, because we have coverage programs. What we don't have is continuity across them. And then, of course, to finish off the pie, or most of the pie, we have to add in the immigrants and coverage gap people into the vehicles that we already have waiting for them.
Thank you, Lou. Yeah, and it's some good comments in the Q&A about like COBRA. You know, we do have these types of continuity vehicles in other contexts, but not in Medicaid, right? So question that's come up in the Q&A, but also kind of relates to something I'd like to pick up next is, you know, the ACA, we've talked a lot about this coverage and access to insurance, but we haven't actually talked about the affordability or what do you actually get with coverage. And so Nicole, maybe you can spend a couple of minutes. I know we're getting close on time, but I just feel like that's an important sort of piece that we haven't covered yet. You know, what do you actually get with coverage? Are needs being met? Is having coverage enough? Even if we kind of go through the exercise that Leo took us through, what do you think about that needs being fulfilled?
I think this is a totally critical question because at the end of the day, most of what the ACA did was try to get people covered. If we were designing a health system, that is not what we would think about first. We wouldn't think about insurance first, delivery system second. And we also would not necessarily think about benefits last. And people are often surprised that Medicaid actually provides the most comprehensive coverage of all of the different kinds of health insurance in the United States. It is more comprehensive than Medicare. It is more comprehensive than most commercial insurance packages. And so people who have commercial insurance, even though they're typically treated by policymakers as if they're playing by the rules of the game and living some kind of golden life, the reality is many, many people who have employer-sponsored insurance coverage are underinsured. They have a very expensive vehicle, which is for a 4-person family now more than $20,000 a year on average. And the next year you have to start all over again. And they're paying deductibles upwards of $1,000. So even after you've paid premiums, you still have to have cash under your pillow just to have insurance coverage. That doesn't even get to the fact of what the insurance actually does for you. And so again, the Affordable Care Act did make it so that essential health benefits became the standard. There is a sort of more common package of benefits that everybody has. But we all also know that that has not done all of the work that is necessary, that people are still afraid to encounter healthcare because they know the cost is too high. There's many reasons that healthcare is nearly 20% of our GDP, but one of them is that we don't take the cost of care particularly seriously in the United States, and we are going to have to. In my view, this is one of the most critical questions that we need to be asking ourselves in next waves of health reform. We need to get past coverage questions, which Leo just very eloquently addressed. And I think Cliff raised this in a different way, right? What are the possible innovations to deal with delivery and cost of care while keeping care quality high, right? These are totally critical questions. I think it's really important to remember that during debates for the 2020 presidential election, most of the candidates on the stage, especially during the Democratic primary conversations, took for granted that we had moved from a place of a public option seeming radical in 2009, 2010, to that being maybe the most centrist position on the stage. So I wouldn't be surprised if the question of a public option doesn't come up again in future presidential candidates' debates. And most of the candidates on the stage were also saying healthcare is a human right. Now, that isn't as broad as the global concept of health being a human right, but I do think the needle has moved in understanding that we should not be facing these questions anymore. And culturally, I think that's an important shift because it helps us to move past coverage questions and it helps us to dive into these other totally critical cost and delivery questions, which I think don't have any great answers right now, unfortunately.
Absolutely. Thank you, Nicole. And so we're just coming close on time. So we've answered a couple of questions live. We're answering some things directly in the Q&A box. But just with our last couple of minutes, maybe I thought I would give Cliff you the last word just for a few minutes as we wrap up. What's next from your perspective? We've looking at this from the perspective of innovation, the incentives, right? You kind of touched on the fact that these incentives are so important to kind of move things towards the direction of health equity. So anything you wanted to add sort of as our final couple words? Oh, muted.
Yeah, very good.
Thanks.
Sorry about that. Yeah, no, I think just that I think we have, I think CMS through CMMI are fairly well focused now on this process of going from, again, a sick care system to a well care system. And as those are cliche words, but they involve a tremendous shift in the way providers and payers interact and the kinds of information that are now necessary for decision-making. And so I think the shifts we're beginning to see through the 1115 waivers that are coming through on health equity. New York is really one of the ones that I think are most interesting in developing separate organizations, which they call, one is Health Equity Regulatory Organization, Regional Organization, which is really going to be designed on assessing needs for a region. And then also a social determinant organization, which is going to, in effect, package social services. So as we see the future, we're going to be looking at what are the needs, what are the social services, how we are going to combine those with clinical care so that decision-making is done in the context of all three. And I think that is a major, major shift in the way healthcare is provided. We're going to move much more towards well care as opposed to sick care. but it's going to be a process. And in many cases, we're going to go kicking and screaming.
I hear you. Well, gosh, I feel this hour has gone by so quickly. We've only been able to sort of touch on some things that I know there's so much there. I might ask Nicole if you can give us 60 seconds. You touched on the preventive care case. I feel like that's such an important thing. If you could share just a brief insight about that, what you feel kind of the impact of that is and how it impacts our conversation here.
So people are probably familiar with the case that's called Braidwood versus Becerra. And the question in the case is whether the USPSTF should have the power to tell health insurers what preventive services they must cover cost-free. It also has a religious freedom element to it, in that there's a challenge to religious employers having to cover PrEP and some forms of contraception. And so the question in the case turns out to be a pretty big administrative law question. How is it that USPSTF is telling health insurers that they need to cover preventive care in certain ways? The big picture questions there are really totally critical, because we already have a problem thinking about preventive care before individual care. And I think that it is hard to say what the outcome will be. It's unsurprising that the judge in the case was critical of the ACA, because he has struck down the ACA every time it's come before him in terms of forum shopping. He's a common forum to head to. But I think it's important to recognize too that this is ongoing litigation and does not impact anybody's access to care at this moment.
Thank you so much for clarifying. That's a really important point. So I will just wrap us up here. This has been tremendous. I want to thank Cliff, Nicole, and Leo. And I also know there's a lot of questions, still unanswered. And I invite you to reach out to these terrific, experts. We provided the contact information in the chat. We can also easily connect you. I know there's a lot of questions and thoughts and work that people are doing in this space. And so we have these wonderful resources, and I invite you to continue to engage. Of course, we welcome you reaching out to me, Asha Shelzo, at the American University Washington College of Law program, or any of our faculty or staff, and engage with us around the work that we're doing. Another big thank you to the American Society of Law, Medicine, and Ethics and the American Health Law Association for their partnership here. And finally, I just want to remind folks that this is a series, and you can look out for our next event, which will be coming up in the fall, on women's health equity. So we hope that you will look at our Future of Healthcare webpage for this recording, as well as the recording we did in January for an event also around health equity. Just again, a deep, deep thanks to Cliff, Nicole, and Leo. We're really grateful for you sharing your time and expertise with us today. Thank you all again, and I hope everyone has a great afternoon.